Why are we all here? It's to learn from each other, right? And we've invited not just the faculty members that you've been able to meet thus far, but also two awesome guest speakers, also peers and colleagues in the field working on maternal and child health. So with that, without further ado, Funmi, may I pass the mic on to you, allow you to screen share some of the slides that you want to highlight today, and thank everyone in the group so far for participating.
Thank you. So good afternoon, everyone. My name is Funmi Makinde. I'm a health equity research analyst with the Association of American Medical College and with the recently founded AAMC Center for Health Justice. The AAMC is a nonprofit association dedicated to transforming health through medical education, healthcare, medical research, and community collaborations. So I've been with the association for about 3 years now, and as part of my role, I'm helping to lead the maternal health equity portfolio for the association. And today I'll be presenting on disparities and barriers for maternal health in the US. So before I get into today's topic, I'd like to briefly provide some more context about the AAMC Center for Health Justice. So after an extensive strategic planning process, the center officially launched last fall and really focuses on ensuring that academic medical centers are the best multi-sector partner that they can be in the fight for health justice. The center's key focus areas include maternal health equity, data for health equity, and the principles of trustworthiness, which is an initiative focused on ways that organizations in healthcare and beyond can work to demonstrate that they are worthy of their community's trust. So you can learn more about the center by visiting aamc.org/healthjustice. And now to really get into the meat of the discussion today. So inequities in maternal mortality and morbidity have been an issue in this country for a long time. I'm not sure if many of you know that the US has nearly the highest maternal mortality rate among high income and developed countries. And within this, Black and Indigenous people who give birth in this country are 2 to 3 times more likely to die from pregnancy-related complications than their white counterparts. This trend, unfortunately, gets worse with age, and having a high level of income or education does not improve these disparities either. It's really important to note that these disparities are not just present with mortality, but morbidity as well, which encompasses any short or long-term health problems that result from being pregnant and giving birth. So in order to understand and effectively address any issues in our present, we have to first reckon with our past. And when we think about the historical context for maternal health disparities in this country and look at those who are most impacted over the years and even to this day, it's really important to acknowledge that during slavery, Black women were often used as experimental subjects in OBGYN practice as the field developed. So there's strong evidence that suggests that this troubling history of medical experimentation on Black people set a precedent for the unequal medical care and misconception of pain tolerance among Black people today. So as I mentioned, education and income are not necessarily protective factors. All of the women pictured on this slide, regardless of their social status, education, or income, all suffered traumatic birthing experiences, and some of them tragically passed away as a result. These are real people, and all of them have a story, a family, a legacy, and these are just the ones that get publicized. The CDC states that almost 2/3 of pregnancy-related deaths are preventable, and in a lot of the scenarios of the women pictured, a common theme was not being heard or taken seriously by medical staff. So here are some graphs published by the CDC, which just further illustrate the disparities I just talked about. Just moving through, I included this graph as well to highlight that these disparities have gotten worse over the years and unfortunately continue to rise. So a recent National Center for Health Statistics report that was released just last month showed that the maternal mortality rate continues to increase in the US. So in 2020, there were 23.8 deaths per 100,000 live births, compared with a rate of 20.1 in 2019. So with the pandemic, there are of course new challenges for birthing people. COVID-19 has had a disproportionate negative impact on communities of color who are already and still are grappling with systemic injustices daily. So when we think about the communities most impacted by maternal health inequities, those who identify as Black and or Indigenous, those living in rural areas, those are some of the same communities who have been hit hardest by the pandemic. And of course, there are social, economic, physical, and mental implications for all of this. So what are some of the barriers and root causes of poor maternal health outcomes? So there are a number of factors that impact the maternal health experience, including different social determinants of health, such as transportation, environment, housing. And so the presence and absence and or quality of these factors can contribute to chronic health conditions such as hypertension and obesity, which increase the risk of maternal health complications. Racism, bias, and discrimination are cited as key contributors to this crisis as well. And it's all connected too. So weathering is a condition where Black women experience earlier deterioration of their health because of the cumulative impact of exposure to psychosocial, economic, and environmental stressors. So for example, conditions like hypertension have been linked to the stress of living in a racist society, and they contribute to disparities in pregnancy-related complications such as preeclampsia. Other factors to consider are the maternal health workforce needs and the data, as well as the data infrastructure that's needed to effectively contextualize these disparities. So how do we move the needle? While it is imperative that we honor the lives lost due to the maternal mortality crisis in the US, it's equally imperative that we do everything in our power to undo it. So of course, this list isn't all inclusive, but here are some of the things that I believe are extremely critical if we're going to eliminate these inequities. So advocacy for and awareness of policies at all levels, such as paid parental leave, extended postpartum Medicaid coverage, those are all needed to create structural and sustainable changes that increase access and quality of the social determinants of maternal health. Workforce development is also a huge component of this and requires investments to address the dearth of obstetric training programs at racial and ethnic minority serving institutions. And so this is why the Momnibus bill is so important, but I won't get into the details. It's a huge bill. But accountability is another aspect. We have a responsibility to ensure that we have the data, which paints the fullest picture of this problem, and to make that data accessible and shareable across different sectors. And so we must move beyond quality improvement implementation and begin to evaluate impact on outcomes as well. Finally, this is what I think is most important in all of this, is authentic community engagement and humility. So we don't know what we don't know, and we should always leave room for learning, relearning, and unlearning. Partnering with communities who are most impacted by this issue is non-negotiable if we really want to make a change. The AAMC's principles of trustworthiness are a really great example and resource for doing this. And one of my favorite principles states that people closest to injustice are also those closest to the solutions to that injustice. So we know that many stakeholders have been doing this work to address maternal health disparities for a really long time. With maternal health equity as one of the Center for Health Justice's key focus areas at the AAMC, we really hope to build on this advocacy as well as the expertise and efforts of communities. And we really want to leverage that expertise as well as the expertise of healthcare practitioners and other multi-sector stakeholders to really address some of these long-standing gaps in maternal health. I'm going to take this opportunity really quickly to plug the Center for Health Justice's upcoming Maternal Health Incubator. That's a 2-day virtual convening happening this May. That's really intended to facilitate the development of a multi-sector action agenda for addressing maternal health inequities. Registration is free, opens next month. and I'm happy to share that information when the time comes. But we're also engaging our community stakeholders to help guide the center's upcoming national polling on issues related to maternal health that are of utmost concern to the public. And in doing this, we're working really closely with our external maternal health equity work group in these efforts, and our members are also tackling this issue as well. And we know that there are some programs that at the local level that are working really well. And some of these programs, not all of them, are highlighted in our maternal health fact sheet, which lives on our site. And I forgot to put the site on the slide, so I can share that as well. And that concludes my presentation. I would really like to thank you all for your time and attention this afternoon. It's really been a pleasure sharing with this group, and please feel free to reach out to me or the center in general at either of the emails listed on the slide. You can also stay connected by following us on Twitter and signing up for our monthly newsletter. So thank you all again, and I'll go ahead and turn it back over to Bethany.
Thanks, Funmi. We also put the URL for AAMC Center for Health Justice in the chat, and you can find Funmi's email address as well in the welcome packet. So please do subscribe to their newsletter so you can keep track of what she shared. We'll be starting up this May. With that, I'm going to pass it on to Kimá Taylor to provide some remarks on child health.
Awesome. Thank you. And again, like Funmi, I want to thank everyone for coming and inviting me today. And I really want to thank Funmi for her comments. I am talking about child disparities, but as a pediatrician, but I really, feel that healthy moms. So I am going to start back and do some maternal child health as well. And as Funmi alluded to, maternal child health history has really created the systems that are defined and created to perpetuate inequities. And so it's really, for my work and the things I do, it's like we can't keep tweaking around the edges. We have to fundamentally, in partnership with legal partners and others, deconstruct current systems and recreate ones that ensure equitable maternal and infant health outcomes. Sprinkling little solutions on the edges aren't going to work because the system was fundamentally created to produce inequities. And that in part goes back to the father of GYN that did torture Black slave women in order to move the field of GYN. But it also goes to the decimation of Black midwives in the South. And when we professionalized and medicalized maternal health care, really denigrated Black and Indigenous midwives and said they weren't doing the job they needed to do, that they were unhygienic, that they were causing disease. And even when this professionalization showed poor maternal and child health outcomes, it continued because the medical profession is such a strong voice, including the AMA. And we took out midwives and we deconstructed to the point where now the majority of midwives are white, and it was due to a resurgence later on. And so we took away not only access to this better field of healthcare, but in doing so, convinced the public that hospitals were better, and then provided money to increase the number of segregated hospitals to really just cement that inequity and making sure we had separate and unequal hospitals and poor outcomes. On top of that, we layered in this lack of reproductive justice. And then we also said, we're going to have lack of access to all healthcare. We're going to make it really hard for people to get adequate, culturally and linguistically effective healthcare. And so it's no surprise that we have really poor maternal child health and, frankly, many other health outcomes and health disparities. And it's no surprise that Black and Indigenous populations have some of the highest rates. So they have higher rates of preterm births, which is births less than 37 weeks. I'm sure you guys know this. Higher incidence of low birth weight infants, which are all leading causes of infant mortality. So it's no surprise also that there's low rates of prenatal care, which is some of the ways that you can try to get better outcomes. And part of that's because we've created systems that are built on exclusion, poor care, punishments, and then we act surprised when people don't come in for prenatal care and have poor outcomes, for which then the parent is blamed and punished, particularly if they're Black and Indigenous. And I deem these as societal determinants of health, no longer social determinants of health. Social has become really about the individual, and many systems think they're going to Uber their way out of that. This is society determining that we are going to ensure that people have poor outcomes. And so it really is requirement of all of us to work together to deconstruct the systems and really reconstruct them. And I'm going to give an example because I do a lot of work in the substance use maternal child health care realm. And just look, so that was that whole baggage around maternal child health and our outcomes. Then we layered on the war on drugs and those disproportionate criminal legal impacts, contacts, harsh punishments, even before a pregnant person gets pregnant. Then there's alternating doses of eugenics, who should have babies, who shouldn't have babies. And we're going to decide that before people are born. And then they're going to add in a little parental separation. And our country has a long history of parental separation, be it from the slavery times, be it indigenous children taken to boarding schools, be it most recently with children at the border. And that is based on who we deem will be positive parents, who we deem can raise their children. This is particularly punitive in the substance use realm, and with CPS rules that change based on the provider decisions, health systems, state decisions, that really aren't focused on wellness and really aren't focused on improved outcomes for mom or the infant or family preservation. Dash in that a little disparate treatment based on the drug that someone uses now, really because of race and other issues. Opioid is the conversation of the day, but we know we need a substance use system. We know from the crack baby history that this is not fair, that you treat one set of parents one way in a punitive way and another set of parents another way, although we are having compassion fatigue, so now we're kind of taking out everyone. And then society acts surprised when we have poor outcomes. And it's truly mind-boggling. And so I think the beauty of the work that you all are doing, the beauty of MLPs, is this recognition that a mix of culturally and linguistically effective services and health and social services and legal support and interventions can reframe this picture, can call for equitable outcomes and have the tools necessary to deconstruct and reconstruct, so we have systems where we have equitable outcomes for moms, infants, and the dyad and their families of choice. It's a real opportunity to give parents a chance. If they're not afraid to come in because they're not afraid of all those punitive consequences, you have earlier prenatal care where the infants have better outcomes. If they're given evidence-based treatments, inclusive of maternal opioid use disorder drugs, inclusive of mental health services, services for your hypertension, services for your cardiovascular issues, guess what? Infants have better outcomes and moms have better outcomes. If people are actually encouraged and supported as other moms to breastfeed, room in, bond, guess what? Better outcomes for infant and moms. And so if supported and able to avoid some of these criminal, legal, and system and civil system shackles, better access to housing, which we all know improves not only recovery for substance use, but just improves health disparities, access to employment, access to education, all of which have been affected by our punitive response to something that's a health and social concern, substance use, all of which we can do better in order to ensure better dyadic outcomes. Equitable maternal child health really requires health and legal and all other systems to face our past history, face our societal barriers, and truly work together to improve outcomes for infants and moms, and frankly, the entire family, and frankly, the entire country. But we need to do it in a way that centers the people that we care about. It's not, there's so many times you work, and I worked on the Hill, where you say, let's do this policy, and don't follow up whether policy was actually effective. Don't take the data to see if there are disparate outcomes. Don't use the data when we find there's disparate outcomes. My God, if I see one more study that talks about disparities and doesn't do anything about it, right, I'm going to die. Like literally, this has been going on for hundreds of years. Let's stop it now and actually do something. And so this is a time, I think, where these partnerships can work together fabulously. And I will say for MLP and Bethany and some of the other MLPs, like really opening the eyes to the civil system, right? People don't even know some of the punishments that go on in there that really lead to these poor outcomes. And so I'm incredibly honored to be a part of the conversation, incredibly honored that you guys are doing the work you're doing, and really hoping that we stop as a society being okay with increments. Well, at least we're treating opioids a little better. Well, at least we're treating this parent a little better, but really seek to overhaul systems so we have the best maternal child health outcomes possible along all spheres of health, not just healthcare, along all populations, regardless of race, ethnicity, sexual orientation, gender identity, ability, immigration status, primary language, and all other intersectional identities. So I really just want to thank you guys for inviting me.
We thank you and Funmi for joining us today. I want to make sure folks know, and I see some claps, hearts, react. Please feel free to react. Funmi and Kimá, both of their email addresses, I took liberty to add them into, since they're not the primary faculty group, but reach out to them, connect with them. They're in this space that you're working in together. We will get to Q&A, so I just want to remind folks, take a moment, use the chat to share questions, because even if we run out of time this afternoon, we did stretch to an hour and a half for today, but we'll collect those Q&A that come in, and any unanswered questions that we may not get to, we'll be sure to follow up via email at least to get some answers, get you pointed in the right direction to resources. Going to turn it over first to our team, the MLP team at Georgetown's Health Justice Alliance. We can hear a little bit more about what they're going to address, what they do in their MLP, and then we'll turn it over to Yale and then see if we have some time to get some Q&A. I know that Funmi may have to leave us before we get to that, so I want to ensure that we say thank you to Funmi first for joining us, as well as Kimá, to help us set the tone for our learning collaborative today. All right, Vicki, you first.
Hi, yeah, and I'd like to express my thanks to you both for creating that incredible framework for the work that we're going to try and get done here. My role is very short because the real stars of this show are Roxy Richardson and Laurel Patchen. So at Georgetown, we have what we call an academic medical legal partnership. So our law center and medical center, School of Medicine, are under that university umbrella, but we're also super fortunate to have MedStar Health as our academic health or academic medical partner. And that is where we have created what we refer to as kind of those clinical learning environments. Because the academic side, I'll make a little pitch for those. What we can do that nobody else can do is train the next generation so they enter practice ready to do the medical legal partnership work. So we do that in service to our community. And the reason we're participating in this particular learning collaborative is because we do have an amazing perinatal MLP. We were super fortunate to pull Roxy Richardson into our work. She was previously at Children's Help in Atlanta, so she has that child pediatric, and now she's got that maternal health lens. And I really appreciate, Kimá, that you highlighted the special place that we hold for midwives, because Laurel Patchen is a shining example of exactly the kind of healthcare that I would want as a mom, and I would want my daughter to get as a mom. And she's just an amazing nurse midwife. So I'm going to turn it over to, I think, Laurel, you're up after me.
Wow, thank you, Vicki. That was quite an introduction. And Roxy really is the star. So what I have to say is really brief. You know, I've been working in this space in DC for almost, well, I guess it's 2.5 decades. And so during that time, my patients have shared a lot with me about what is important if your goal is ultimately to create an environment where people feel safe interacting with the healthcare system. And part of creating that kind of environment is being able to listen more and to listen more completely. And you know, it was not a surprise to me, because patients were sharing a lot of their lives with me as I learned how to be a midwife, that we eventually got to language and awareness around what we now call social determinants of health, because those are the things that were so very centered in my conversations with folks over the years. And the hard part is that my training in, you know, in midwifery and my role in our system doesn't prepare me to be very helpful to people around a lot of those things. I'm not trained in a very robust way on how to respond to food insecurity or how to respond to housing challenges. I get a little bit of training, especially now. If you weren't trained 25 years ago and more like 2 years ago, you know, you're going to get more on screening and response and to, you know, some of the kinds of social determinants that we know are really important, but it's an incomplete preparation for what we need to do to fully support people. It certainly is a really incomplete training if what we really want to do is try to figure out how to, as Dr. Taylor said, reconstruct a system and figure out how to approach care that is not incentivized to harm people. So when I learned about medical legal partnerships, it was like the air that was needed in the room, because knowing that there is another role, there's another person who is equipped to help people problem solve in those areas. It was one of the most empowering kinds of wake ups that I've ever had. It made it so much easier for me to want to lean into those conversations, because I then had a potential process and set of resources to be able to follow up on. And it was a really satisfying way to start to think about reinventing the work that we do in the healthcare space, because it also is a really concrete way to recognize that we need a very different kind of system in order to support families and in order to promote healthy outcomes. And there's probably nothing quite as different in healthcare these days as looking at attorneys as a partner and as your number one problem solving friend. So that was, I think our rationale. That's where the sort of hope and the vision started, which was we could really try to go ahead and own our desire and our responsibility to ask questions that we weren't really doing a very good job of, that we weren't approaching systematically and we weren't doing consistently. And it made it very possible to engage a range of providers in a commitment to that, rather than just the one or two folks that sort of had a life history, an origin story, or a passion around the need to build a more just system, because we were providing resources and we were recognizing that we didn't have to try to have all the answers. We needed to be part of a team that could really center around the patient. So I think that's what I have to share right now. And I will enjoy whatever it is that Roxy has to share with us.
Thank you, Laurel. So hi, everyone again. What we realized going into this, we had a needs assessment that was done to try to see from the hospital, from MedStar side, what were the issues that were affecting the patients in particular. But also our own evaluation research has found that, as you can see on the slide, housing insecurity during pregnancy has been associated with increased risk of low birth weight and or preterm birth and extended hospitalization. Food insecurities, like Laura was talking about, it's also associated with perinatal and maternal depression and anxiety. And low birth weight and preterm births are increased among women who are exposed to domestic violence. And so PLAW is actually one of the few perinatal focused MLPs in this country. And so what we see is that there is a need for legal services for these patients, but there's not a lot of literature on that. And so on that in regards to the MLP world. And so that's where we come in. And it's a really unique and exciting time for us to be able to demonstrate the effectiveness of the MLP model for this particular vulnerable population of perinatal patients. And so at PLAW, so I work with the healthcare team, the staff there. We provide legal services to the pregnant and postpartum patients to address the barriers to their health and well-being. We are also, as Laurel said before, 2 years ago, 25 years ago, this type of training would not have been done. But now at the hospital, we do train the providers with their patients to help with their legal needs of identifying how and to refer patients to us and identifying what those legal needs are that their patients are currently going through. And then we also, as Vicki mentioned, we are an academic MLP, so we do provide opportunities for Georgetown students to engage in the MLP model. And then we have a fantastic research and evaluation team, and they also are assisting us in showing the impact on the patients, the providers, and the health system to contribute to that MLP evidence base of just how this is a life-changing model that should be in all systems. I know in all healthcare systems, but we're starting from here. So in session 2, you will learn in greater detail about the health harming legal needs that perinatal patients face, maternal patients face, a real world application through the case study and then the tools also to apply that in practice. So we are so looking forward to seeing you all in 2 weeks when we start our maternal health chat. And I will turn it over back to you, Bethany. Thank you.
Thank you. Thank you. Thank you all. I'm going to quickly turn over to Alice and Ada to talk about their work at CCA and Yale New Haven, and remind every one of the participants that, yes, we're running tight on time. So chat your questions and comments, because we'll collect them and follow up. Ada and Alice, can I pass it on to you now?
Absolutely.
Thank you.
So I had a very similar story to Laurel's, where I felt, and this is a wonderful tweeted cartoon by Dr. Jack Maypole, who's out in Boston. A lot of Boston people might know him, but he tweets a lot of wonderful things. And he said we could reuse this. This is kind of how I felt. This was me thinking that I was really taking care of kids, looking in their ear, everything is better, all wonderful. And of course, I wasn't really thinking about what really surrounds the kid, which is the family and everything the family is facing. So while the ear might be somewhat better, the food, the rent, the heat, the school, everything is weighing on the parent. And I agree with Julie, this cartoon is so real, which is why we keep using it, why I begged him to let me use it in national presentations. So yay, Jack Maypole. So this is how I felt. And then this amazing thing happened. A medical student who was a joint medical and legal student came to me and said, have you heard of this thing called a medical legal partnership? And I said, are you kidding me? Lawyers sue doctors. Why would I ever talk to a lawyer, right? And that was my initial reaction. And that was awful. And I thought, okay, but let me listen to this. And he talked about how lawyers could maybe address some of these issues. And I was sold. I went to a pre-meeting at this Pediatric Academic Societies meeting, which was all about MLP. It was an MLP one-day meeting. I met some people from Providence and people from a couple different places in the country. And I started agitating to get an MLP at our children's hospital. So it took, I think, 7 or 8 years, and the agitating came in the form of, helping get a grand rounds about MLP and legal partnerships and all sorts of things like that. And we finally partnered. We found an agency called the Center for Children's Advocacy, which is a statewide Connecticut agency that partnered with us to create this MLP. So this is a picture of me and Alice, who you see, and our social worker in our office. You can see one of our nurses in the background, to really have a lawyer in our office. And I call Alice our lawyer for children's health, because really that's what she is for us. So the idea is to improve the health outcomes for children of families with low income through interdisciplinary medical legal collaboration within the healthcare or clinical setting. People come to the pediatrician, and we should help them with more than just their ear infection, eczema, or whatever it is. And now I feel like we couldn't ask these questions before, and now I felt having Alice around that we can. But it's even more than that. So we're going to go to the next slide, and Alice is going to explain our philosophy.
Just really quickly, the Center for Children's Advocacy LP is a little unique in that our legal service agency is a very small nonprofit. We're not your traditional legal services office, so we focus on kids. So it's a little bit, it holds us back on our MLP that we aren't able to do more adult stuff, because we really are child-focused lawyers. But our MLP was I think the second MLP in the country back in 2000 up at CCMC in Hartford, and then we expanded to Yale in 2013. So been around for a long time, and Yale was like, okay, we trust you because you didn't sue CCMC, so okay. But I think that can be some of the hurdles. So, but Ada and I always one thing is our organization always likes to talk about, we bring legal services to families. We have a school-based health center, a school-based law clinic. We have a mobile legal clinic. We're in pediatrician's office, because why do we have to send people to the next place and the next place and the next place? And so providing holistic care right there in the waiting room is really important. And at our organization and our MLP, and we'll expand upon this in session 3, we really do what Ada likes to call our 3-legged stool, or our trifecta approach to advocacy for patients. We do a ton of education and training. So we do at least one presentation a week. and to medical students, residents, fellows, social work attendings, anyone who will listen. But then we also do a ton of trainings in the community as well. And the idea is that's our screener, is teaching people how to screen and think about these issues in their day-to-day practice, and not just have the medical assistant or someone filling out the screener, but having everybody here at the Children's Hospital thinking about legal health as part of healthcare. Then from that, we get 1 million referrals and consultations. So about 50% of the work that I do is just providing little brief information to providers to give then to the family, so you don't have to re-traumatize families to tell their story again, but say, here's the resource, here's your rights. And then the other 50% I do represent and help families, but we get about 300 to 400 referrals a year just to our one MLP. We have a couple other here at Yale for adults, but this is for our pediatric MLP. And then the third leg of the stool is that systemic advocacy that that Kimá talked about earlier, about really trying to say, wait a minute, we don't want to just put Band-Aids on these individual problems, but how can we shake up the systems and change systems? But again, it's just me and Ada in our MLP, so we can do some systems change, but not tons. That came from a press conference this morning with the governor's office. We have bills at the legislature. So we're trying to do a little bit of all of it, because it's really important that the individual stories impact our systemic advocacy. I think was said earlier that it really is about people impacted by these systems that should be the ones making the change. And so taking their stories and then making sure they're part of the solution. So that's our 3-part approach. And then I think we have one last slide. And we're also going to, we're going to dive into this a lot more in the third session, but really want to hear from all of you in the third session. We are going to focus more on what are some of the legal issues. I know some people put in the chat questions about different legal issues, but we are going to focus on specific ones that we work on in the children's realm, and specifically for the Children's Hospital and the Federally Qualified Health Center that I work with, but use it in the context of a case study and sort of talk through some of the nuts and bolts of how do you use that 3-legged stool to impact the work that you want to do, because some MLPs want to focus more on policy, some want to focus more on individual, some want to focus more on just sort of that brief consultation. And so thinking about how you can do that. So we're excited to work with all of you. Thanks so much.
We're excited to have you here, Ada and Alice. Thank you so much. Before we run out of time, I want to make sure, working from our participants, our grassroots here, to our faculty teams and special guests, I say thank you, thank you, thank you, participants, for engaging in the conversations in that icebreaker activity and get you feeling comfortable with sharing with each other. The point of this learning collaborative is also to allow you to feel comfortable with reaching out to one another. So you'll see us at the National Center team in those follow-up emails also asking you, would you like to go ahead and share your contact information with other participants? To our faculty members from the DC area and Connecticut. So this is Vicki, Roxy, Laurel, and then Ada and Alice. Thank you so very much for being our faculty members on the Learning Collaborative this spring. To Dr. Kimá Taylor and Funmi Makinde, both had to hop off, or one's on by phone. I want to thank them as well for helping us really set the tone and understand what are disparities that are being faced around the country, and they are historical, and it's time for them to end. And this is one way we can end it. It's through the medical legal partnership approach. With that, because I know we're out of time and folks have to then probably jump to the National Center's webinar starting at 4 p.m. today. Thank you, thank you, thank you. I see some applauses. We'll see you back here on March 17th at 2 p.m. Eastern time. Thanks, everyone. That's a wrap.